Good day everyone, I am Maria Elijah Marfil, a BS Nursing 2E student, and I'll now present a topic about anti-diabetic. In this presentation, I'll be introducing anti-diabetic drugs, different types of drugs, its uses and side effects, and the nursing process. Anti-diabetic drugs are used primarily to control diabetes mellitus, a chronic disease that affects carbohydrate metabolism. We have two groups of anti-diabetic agents, namely insulin and oral hypoglycemic. Insulin is a protein secreted from beta cells of the pancreas, is necessary for carbohydrate metabolism, and plays an important role in protein and fat metabolism. Oral hypoglycemic, also known as oral anti-diabetic drugs, are synthetic preparations that stimulate insulin release or otherwise alter the metabolic response to hyperglycemia. Diabetes mellitus is a chronic disease that results from deficient glucose metabolism, is caused by insufficient insulin secretion from the beta cells. This results in high blood glucose or hyperglycemia. 3Ps includes polyuria, which is an increased urine input, polydipsia, an increased thirst, and polyphagia, an increased hunger, which are the main symptoms of diabetes. Individuals experiencing these symptoms should seek medical attention immediately. The four types of diabetes. Type 1 diabetes is a condition in which your immune system destroys insulin-making cells in your pancreas. These are called beta cells. The condition is usually diagnosed in children and young people, so it is used to be called juvenile diabetes. Type 2 diabetes is a lifelong disease that keeps your body from using insulin the way it should. People with type 2 diabetes are said to have insulin resistance, and some sources suggest that heredity and obesity are the major factors that causes type 2 diabetes. People who are middle-aged or older are most likely to get this kind of diabetes, and it is used to be called adult-onset diabetes. Secondary diabetes is diabetes or glucose intolerance that develops from disorders or conditions other than type 1, type 2, or gestational diabetes. Gestational diabetes is diabetes diagnosed for the first time during pregnancy or gestation. During the second and third trimesters of pregnancy, the levels of hormones, progesterone, cortisol, and human placental lactogen increase. Insulin is released from the beta cells of the islets of Langerhans in response to an increase in blood glucose. Beta cells secretion of insulin. The beta cells in the pancreas secrete approximately 0.2 to 0.5 units per kilograms per day of insulin. A patient that weighs 70 kilograms secretes 14 to 35 insulin per day, although more insulin secretion may occur if the person consumes more calories. Commercially prepared insulin. Early insulin preparation utilized pancreas tissue extracted from animals, either pigs or cattle. For pork, insulin is almost similar structurally to that of human insulin than beef. Human insulin duplicates insulin produced by the pancreas of the human body. The use of this insulin has a low incidence of both allergic effects and insulin resistance. The examples of human insulin are Humulin R or Novolin N. The human insulin analogs are modifications of human insulin with alterations in onset and duration of action. The examples of human insulin analogs are insulin lispro and insulin aspart. Insulin is a protein and cannot be administered orally because gastrointestinal secretions destroy the insulin structure. It is administered subcutaneously at a 45 to a 90-degree angle. The site and depth of insulin injection affect absorption. Insulin absorption is greater when given in the abdomen than when given in the thigh or buttocks. Heat and massage could increase subcutaneous absorption, and cooling the subcutaneous area can decrease absorption. Insulin injection sites should be rotated to prevent lipodystrophy, tissue atrophy, or hypertrophy which can interfere with insulin absorption. Lipodystrophy is a well-known fact that insulin application into such skin areas induces erratic insulin absorption. Lipoatrophy or tissue atrophy is a depression under the skin surface that primarily occurs in women and children. while lipohypertrophy or tissue hypertrophy is a raised lump or knot on the skin surface that is more common in men. It is frequently caused by repeated injections into the same site. Rapid-acting insulins include insulin lispro, human insulin aspart, insulin glulisine, and human oral inhalation insulin. Insulin lispro is formed by reversing two amino acids in human regular insulin. Insulin aspart or the rDNA origin is another human insulin analog in which a single amino acid or proline has been substituted with aspartic acid to help prevent the molecules from clumping together to allow quicker entry into blood circulation. Short-acting insulin. Regular insulin is a short-acting insulin that can be administered intravenously or subcutaneously, has an onset of action of 30 minutes. The peak action occurs in 2.5 to 5 hours and the duration of action is 4 to 12 hours. Regular insulin is generally given 30 to 60 minutes before meals. Intermediate-acting insulins include neutral protamine hagedorn. Isophane insulins like NPH contain protamine, a protein that prolongs the action of insulin. The onset of intermediate-acting insulin is 1 to 2 hours, peak action occurs in 4 to 12 hours, and the duration of action is 14 to 24 hours. Glargine was the first long-acting rDNA human insulin for patients with types 1 and 2 diabetes. Glargine, Detamir, and Degludec are available in a pre-filled cartridge for the OptiPen insulin pen device, prior to the soft copies being given. Hyperglycemia on awakening is known as the dawn phenomenon. The patient usually awakens with a headache and reports night sweats and nightmares. Management of the dawn phenomenon involves increasing the bedtime dose of insulin. Let's talk about signs and symptoms of hypoglycemic reaction and diabetic ketoacidosis. So when you have a hypoglycemic reaction or insulin shock, you may experience headache, lightheadedness, nervousness, apprehension, tremor, excess perspiration, cold, clammy skin, tachycardia, slurred speech, memory lapse, confusion, seizures, and your blood glucose is less than 60 milligrams per deciliter. And when you have diabetic ketoacidosis or hyperglycemic shock, you may experience extreme thirst, polyuria, fruity breath odor, small breathing or deep, rapid, labored, distressed dyspnea, rapid, thready pulse, dry mucous membranes, poor skin turgor, and your blood glucose is over 250 milligrams per deciliter. Insulin pen injectors resembles a fountain pen but contains a disposable needle and disposable insulin fill cartridge. Insulin pen comes in two types, which are pre-filled and reusable, and are considered to deliver a more accurate dose than a traditional 100-unit syringe and vial. Insulin pens available on the market include the Novolog Flex Pen or Novo Nordisk, Humalog Quick Pen or Lilly, Apidra Solostar or Sanofi Aventis, Lantus Solostar or Sanofi, and Levemir Flex Pen or Novo Nordisk. Insulin pumps are an alternative to daily insulin injections used in association with blood glucose monitoring and carbohydrate counting. These computerized devices have an insulin reservoir and programming capacity to deliver continuous rapid-acting insulin in varying amounts at different times throughout the 24-hour period. The implantable insulin pump is surgically implanted in the abdomen and delivers both basal infusion or continuous release of a small amount of insulin and bolus or additional doses with meals. It is administered intraperitoneally. External or portable insulin pumps, also called continuous subcutaneous insulin infusions, may have a tube or infusion set placed under the skin. The needle is inserted into the abdomen, upper thigh, or upper arm. This type of pump is worn outside the body and is placed in a pocket or bra. The external tubeless pump lies directly on the skin and injects insulin through the skin without tubes. The external insulin pump keeps blood glucose levels as close to normal as possible. The insulin jet injectors shoot insulin without a needle directly through the skin into the fatty tissue. Because the insulin is delivered under high pressure, stinging, pain, burning, and bruising may occur. This method of insulin insertion is not indicated for children or older adults. This type of device is also expensive, costing approximately 2 to 10 times as much as the subcutaneous dose. So the nursing process, patient-centered collaborative care, anti-diabetics, insulin. Identify the drugs the patient currently takes. Certain drugs such as alcohol, aspirin, oral anticoagulants, oral antidiabetics, beta blockers, TCAs, MAOIs, and tetracycline increases the hypoglycemic effect when taken with insulin. Note that thiazides, glucocorticoids, oral contraceptives, thyroid drugs, and smoking can increase blood glucose. Assess the type of insulin and dosage. Note whether it is given once or multiple times a day. Note blood pressure, heart rate, and blood glucose levels. Tachycardia and heart palpitations may occur with hypoglycemia, and hypotension may occur with hyperglycemia. Report abnormal findings. Determine the patient's knowledge of diabetes mellitus in the use of insulin. Check for signs and symptoms of hypoglycemic reaction or insulin shock, hyperglycemia, or ketoacidosis. Nursing diagnosis, skin integrity, risk for impaired nutrition, readiness for enhanced related to excessive intake associated with a metabolic need, injury, risk for knowledge, deficient related to inexperience with insulin therapy. Planning. The patient's blood glucose will be within normal value 70 to 99 milligrams per deciliter, and the patient will self-administer insulin correctly. Nursing interventions. Monitor vital signs. Tachycardia can occur during insulin reaction. Determine blood glucose levels of 70 to 99 milligrams per deciliter and report changes. Monitor the patient's hemoglobin A1C to provide feedback on diabetic control. Prepare a teaching plan based on patient's knowledge of the health problem, diet, and drug therapy. Evaluate the effectiveness of insulin therapy by noting whether the blood glucose levels is within the accepted range. Establish the patient's ability to perform self-care, and determine the patient's knowledge of the signs and symptoms of a hypoglycemic or hypoglycemic reaction. Oral antidiabetic drugs or hypoglycemic drugs should be used by those with type 2 diabetes. Persons with type 1 diabetes should not use them. Patients with type 2 diabetes should have the degree of insulin secretion by the pancreas. So let's discuss two generations of sulfonylurias, which is the first generation and the second generation sulfonylurias. The first generation sulfonylurias are generally preferred when there is poor function of the kidneys. These are divided into short, intermediate, and long-acting antidiabetics. Tolbutamide is a first-generation short-acting sulfonylurea, which may cause headache, dysgeusia, pyrosis, hypoglycemia, weight gain, weakness, dizziness, and blurred vision. Tolazamide is a first-generation intermediate-acting sulfonylurea, which may cause weakness, fatigue, dizziness, headache, blurred vision, weight gain, and hypoglycemia. And chloropropamide is a first-generation long-acting sulfonylurea, which may cause headache, dizziness, blurred vision, hypoglycemia, and weight gain. So this table is the first-generation sulfonyluric drugs and their uses and conditions. So for a clear copy, please refer to your own copies being given. So the second-generation sulfonylureas increases the tissue response to insulin and decrease glucose production by the liver. Second-generation sulfonylureas include glimepiride and glipizide, which directly stimulate the beta cells to secrete insulin, thus decreasing the blood glucose level. They have a greater hypoglycemic potency than first-generation sulfonylureas. Effective doses for second-generation drugs are lower than for the first-generation drugs, while the second-generation drugs also have a longer duration of action and cause fewer side effects. Glimepiride improves postprandial glucose levels and may be used in combination with insulin in persons with type 2 diabetes. Side effects include GI disturbances such as nausea, vomiting, diarrhea, and abdominal pain. The table above shows the different second-generation sulfonylurea drugs and their uses and conditions. So for a clear copy, please refer to your own copies being given. The side effects of most oral anti-diabetic drugs are similar to those of nervousness, tremors, and confusion. Adverse reactions include hematologic disorders such as aplastic anemia, leukopenia, and thrombocytopenia. Weight gain, seizures, and coma may also occur. Sulfonylureas are contraindicated in type 1 diabetes, diabetic ketoacidosis, pregnancy, lactation, and during stress, surgery, or severe infection. Metmorphin is a biguanide compound that acts by decreasing the hepatic production of glucose from stored glycogen. This diminishes the increase in serum glucose following a meal and blunts the degree of postprandial hyperglycemia. For a clear copy, please refer to the copies being given. Pioglitazone and rosiglitazone are examples of thiazolidinedione drugs. Both drugs are contraindicated in class 3 and 4 heart failure. Repaglinide and ateglinide are classified as meglitinide oral anti-diabetic agents. They stimulate the beta cells to release insulin. The action of repaglinide and ateglinide is similar to that of sulfonylureas. These agents can be used alone or in combination with metmorphin for patients with type 2 diabetes mellitus. They are short-acting anti-diabetic drugs. So the table below are the meglitinide drugs and their uses and conditions. So for a clear copy, please refer to your copy being given. Patient-centered collaborative care of oral antidiabetics. Identify drugs the patient currently takes. Aspirin, alcohol, sulfonamides, oral contraceptives, and monoamine oxidase inhibitors increase the hypoglycemic effect. A decrease in the oral antidiabetic drugs may be needed. Glucocorticoids, thiazide-diuretics, and estrogen increase blood glucose. Note vital signs and blood glucose levels and report abnormal findings. Determine the patient's knowledge of diabetes mellitus and use of oral antidiabetics. Nursing diagnosis. Injury risk for nutrition, readiness for enhanced related to excessive food intake, knowledge deficient related to lack of exposure to teaching about taking adequate food with oral antidiabetics. Planning. The patient's blood glucose will be within normal serum levels of 70 to 110 milligrams per deciliter. The patient will adhere to prescribed diet, blood testing, and drug regimen. The patient will demonstrate knowledge of oral hypoglycemics and their importance. Nursing interventions. Determine vital signs. Oral antidiabetics increase cardiac function and oxygen consumption, which can lead to cardiac dysarrhythmias. Administer oral antidiabetics with food to minimize gastric upset. Monitor blood glucose levels and report changes. Reference value is 60 to 100 milligrams per deciliter for blood glucose and 70 to 110 milligrams per deciliter for serum glucose. Prepare a teaching plan based on the patient's knowledge of health problems, diet, and drug therapy. Evaluate the effectiveness of a drug therapy by noting whether blood glucose levels are within the accepted range. Determine the patient's knowledge of the diabetic regimen. Hyperglycemic drugs. Glucagon is a hyperglycemic hormone secreted by the alpha cells of the islets of Langerhans in the pancreas. Glucagon increases blood glucose by stimulating glycogenolysis or glycogen breakdown in the liver. Oral diazoxide, which is chemically related to thiazide-diuretics, increases blood glucose by inhibiting insulin release from the beta cells and stimulating the release of epinephrine from adrenal medulla. Thank you for giving your time and attention and listening to my presentation. Thank you and good day, everyone.